So I will ask Dr. Thomas the last talk. So specific consideration for glaucoma surgery in angle closure disease. And this is the last talk. Then we have lots and lots of time for discussion.
Thank you, Raju. Good morning. In angle closure, we have more pre-op, per-op and post-op events that can happen more commonly than in an open angle. Primarily, we have a shallow AC to start with, and it can be made worse with choroidal effusion, suprachoroidal hemorrhage, malignant glaucoma. All these are more common when you're taking on an angle closure, and it is always preferable to have a PI in place. This one can give us a little more space in the anterior chamber and avoid pupillary block as a mechanism for shallowing per-op and post-op as well. And it also is expected to reduce aqueous misdirection, which is more common in angle closure. And whenever possible, stop pilocarpine if the patient's on pilocarpine already, to stabilize the blood aqueous barrier and again reduce the chance of a malignant glaucoma occurring. What is the difference about these eyes as compared to the open angle eyes? One, the baseline IOP often is a little higher than open angle, even in a chronic closure, and especially it will be much higher when you are dealing with an acute closure. There is a crowded anterior segment to start with, and not just the anterior segment, there is a crowded anterior part of the eye. Even behind the iris is a little bit more crowded. Anterior vitreous phase is closer to the lens equator to start with itself. Decompression is when events actually start to occur. What starts most of these events is decompression. A sudden decompression can start off transudative suprachoroidal effusion, and once the effusion starts, it tends to continue unless the IOP goes high enough to send all the fluid out of the choroidal space. Peripheral AVF gets into apposition. As you can see, there is a ciliochoroidal effusion, and because the ciliary body is rotated inwards, it gets closer to the lens equator, which is barely visible there in this UBM. And once that apposition happens, it's easier for the aqueous to misdirect and cause a malignant glaucoma. Sudden decompression can also start off a bleed in the suprachoroidal hemorrhage, and if you do not let's suppose your video which I'm supposed to click. Anyway, can be expulsive if it's not recognized fast and closed off. This, where are we? Yeah. This was a case where I was planning a cataract plus triple. It's playing here, but it's not playing there. Yeah, anyway, basically what you're seeing up there is the ora serrata, which has managed to reach halfway through a pupil by the time I managed to close off the wound. And I was lucky that it didn't actually get into the wound, then the prognosis gets very bad. The idea is to close off as soon as possible. Each of us runs the risk of this with any intraocular surgery, but in closure, when we're looking at higher pressures, especially in older age group people, it can bleed. And I just continue. Anyway, in this situation, there's all panic, and you close with any whichever sutures you can. Here I use a continuous after closing the middle with a box suture. It gives you a second chance. We did go in for vitrectomy afterwards, and final visual acuity, mind you, was 6.9 for this patient. How do I get back to my presentation? Can I get back to the PowerPoint? Yeah. So this issue, the management actually starts before the surgery, reduce the initial IOP when you're opening the eye, medically, topical, with topical as well as systemic medications, mannitol as required, Diamox as required. And post-block, the massage has to be given. It does indent the cornea, and when you indent the cornea, whatever angle can open up will open up, and that also helps in reducing the IOP. And first step in trab and angle closure should be a controlled paracentesis, slow, deliberate paracentesis, which decompresses the eye very slowly. Don't go stab straight in, go halfway with the blade and wait for one drop to leak out before you complete the paracentesis. Crowded anterior part of the eye, when there's the slightest of cataract, I would go for a cataract surgery as well in closure when we are thinking of a trap. But as Shefali already said, we have very little space in the anterior chamber and the lens is sticking out a lot more. Doing even a rhexis on these cataracts is difficult. Doing a cataract in a closure needs a different skill set than a regular cataract. To get rid of the crowded anterior part of the eye, at the end of surgery, I do put atropine in all my cases of closure. Actually, I do put atropine for all my traps, and this would pull the ciliary body away from the lens equator as well as pull the lens iris diaphragm backwards, and it reduces the chance of aqueous misdirection post-operatively. Hypertony in the post-op, this can also lead to choroidals. So finish a trab in a closure with a fairly firm eye, use releasable sutures or plan suture lysis, but only after 2 weeks. First 2 weeks, be conservative, use massage or if needed, medications, and actual decompression should happen slowly over a period of time. And relative hypertony can happen in very high pressures as in acute closure. If the starting IOP is very high, the drop to even what we call normal is a big drop, and this can start off a choroidals. So once again, finish with a firm eye when you're finishing a trap. Short axial length, when your axial length is less than 20, expect NANOF also as a possibility, measure the scleral thickness, and if that is suspect, we go for a prophylactic sclerotomy, sclerectomy, and that helps in reducing complications. Recently, a couple of studies have been published where they said the PACG patients tend to have thinner anterior sclera. This may have implications in dissecting the scleral flap for the trab, and success rates are poorer in acute angle closure than in chronic angle closure with trab, and there is a suggestion that we do cataract surgery alone if trab looks difficult in an acute angle closure, but I don't know how it works out because usually you have bad visualization in addition to the extremely shallow chamber. The cataract surgery itself is going to be difficult, but I would be happy to combine it with the trab. Thank you. Agreed, agreed. Because and trap does induce. Also, trap induces cylinder also quite often, because so that also is avoided. So your visual rehabilitation is better. And acute closure, if it's for a short time, synechia are not there. So you would expect